Thank you for joining us for this evening's webinar. The Bassler Center for BRCA at Penn Medicine's Abramson Cancer Center is the first and only comprehensive center solely devoted to funding research across the globe, educating providers and patients, and advancing care for individuals with BRCA1 and BRCA2 gene mutations. Dr. Edward and Mary Prostick have generously established this webinar as part of the Elizabeth Prostick Memorial Outreach Program in memory of their daughter. The following video is a tribute to Elizabeth, her incredible life, and her dream of creating communities that increase awareness about BRCA and metastatic cancers. The Bassler Center is proud to be a part of this mission by providing life-saving information and hope to individuals and families worldwide. Please begin the video.
Tomorrow, bet your bottom dollar that tomorrow there'll be sun.
Lizzie Prostick was an amazing young woman who believed in the promise of tomorrow. And though her tomorrows were cut short, we can celebrate and sustain her optimism. Lizzie lived large. She loved the stage and brought it to life with her voice and her energy as a talented child and as she grew into a woman. Her world was full of loving friends and family, and success in class, in sports, with girls, and with boys. Sophomore year of college, Lizzie met Michael Lundblad, a liberal and an English major. He got a preview of her leanings when he saw her quizzing a friend about senators. But she learned to love camping. He learned about couture. And political opposites, Michael and Lizzie spent 10 years together, marrying their minds and their passions. Michael loved her boldness and her softness, her interest in so many different types of people, and ability to remember the small details of their lives. The time she made to talk with her grandmother, her pearls, her red shoes that said she was not afraid to be noticed. She was not afraid. Lizzie's intellect and drive were rewarded with exciting opportunities. She blazed through the University of Pennsylvania and into the halls of government, determined to win in every venue and for every cause that was important to her. Her work for senators and on committees quickly made her a Washington insider. She rose to Chief Privacy Officer and Senior Advisor to the Secretary of Commerce before being lured away to the private sector. Not yet a lawyer, she was named Managing Director at Sonnenschein, Nath, and Rosenthal in Washington, D.C., and was completing her law degree at night at George Washington University when she died. When Lizzie was awarded a posthumous degree at the law school graduation, the entire audience stood in tribute to her spirit. Lizzie was 31 when she was diagnosed with stage 4 metastatic breast cancer, and her daughter Harper was 4 months old. Michael did research. Lizzie didn't want to know the odds, expecting to beat them. But the cruel reality was that although breast cancer is generally curable, metastatic breast cancer is not. And they found little support to help them deal with the psychological and emotional realities they had to face. In her last months, Lizzie and her family began to envision an online support network that would show patients with metastatic disease that regardless of how long they have to live, they have the ability to control how they live. This was Lizzie's final cause, and one which will be honored. Lizzie wanted to see her daughter's first birthday. She didn't make it, but she lives on in the people who loved her, and through grants such as this one being made in her name. And in truth, none of us knows how long we'll live, so we all should listen to Lizzie and make the most of every tomorrow. Live large, live strong, and wear red shoes.
Today's program will look at advances made in BRCA-related research over the past year and will highlight important work that will be ongoing in 2020. As always, this presentation will be archived and available for viewing later this week at basser.org/webinar or on our YouTube channel. I'd like to introduce our speaker, Dr. Susan Domchek, who is a board-certified medical oncologist, Basser Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania, Executive Director of the Basser Center, and Director of the Marion and Robert McDonald Cancer Risk Evaluation Center at the Abramson Cancer Center. An elected member of the National Academy of Medicine and American Society of Clinical Investigation, Dr. Domchek is also a member of the American Society of Clinical Oncology. Her work focuses on the genetic evaluation and medical management of individuals with inherited risk factors for cancer. Dr. Domchek is particularly interested in developing new cancer therapies, such as PARP inhibitors, for breast cancer patients due to genetic risk factors. And Dr. Domchek, the floor is yours.
Thank you so much, and thanks to you all for joining us here today. As always, we will be reviewing some basic information, but then taking the opportunity to answer our questions. And fortunately, a lot of you have submitted questions in advance, and so we'll be sure to try to get to as many of those as possible. Just to review some basics of the Basser Center, our mission is to use cutting-edge research in basic and clinical sciences to advance the care of individuals living with BRCA1 and 2 mutations. We have a lot of different initiatives, including funding that we provide both internally at the University of Pennsylvania, but also external grants which we give out to other organizations. In addition, we have an annual scientific symposium, which this year is May 12th and 13th. This is our 8th annual symposium. We have always a packed conference hall. We have international faculty lecturers. And we do award the annual Basser Global Prize and have a keynote address at this time. This has, for those of you interested in continuing education credits, that's available as well. Our registration is open. We also have a Breakthrough and Discovery panel, which is more focused at layperson level, which is open to the public, and that will be open soon. We really sort of welcome anyone to join us, and particularly the Breakthrough and Discovery can be very useful for individuals who are kind of just getting used to the topic. This year we have a joint Global Prize winners of Doug Easton and Antonis Antonou, who have both been extremely involved in the epidemiologic aspects of BRCA1 and 2 related cancers. Here you have listed our previous award winners, which range from Alan Ashworth, Mary Claire King, David Livingston, and on. And so it's always a really interesting and exciting symposium. In addition, this past year, we did a large number of outreach events, which is something that we do a lot of. We had 5 panel discussions in New York, California, and Pennsylvania in collaboration with the Basser Young Leadership Council, Shasheri, and other partners such as UGA of New York. We've had multiple webinars, such as this one. We also have external organization sponsorships with organizations like Force and Charsheret. We have launched a Latinx and BRCA initiative due to the significant under-testing for genetic susceptibility, such as BRCA1 and 2, in individuals of Latina descent and also individuals, other underrepresented minorities. So we are also about to launch a Black and BRCA initiative, again with information for providers and patients. We have also been really working on decreasing barriers to genetic testing. I talked about a little of this last year, and just to provide an update, we acknowledge that the way that this information can be useful is if people have it. And therefore, there's a lot of ongoing studies using telegenetics, digital health platforms, what we call point-of-care testing, and also leveraging the electronic medical record. So there's not a one-size-fits-all approach to this. We believe that with appropriate pre-test education, if individuals know the risks and benefits of genetic testing and what genetic testing they're receiving, we want to provide different ways for people to get this information. The electronic medical record, although you may hear bad things about it from various physicians, there's a lot of advantages to the electronic medical record in terms of what you're able to do for identifying individuals at risk. This is important because we know that too few people at high risk get testing. We're particularly bad at testing people who had cancer in the past. If you come in now with a new diagnosis of breast or ovarian cancer, usually, although certainly not always, individuals are offered genetic testing if they're at risk of having a BRCA1 or 2 mutation. But we know from studies that were done a few years ago that people who had ovarian cancer in the past, ovarian cancer survivors, a shockingly low number, 10% in this study. Another study showed 25% of ovarian cancer patients have been tested. And the guidelines state that every ovarian cancer patient should be tested. So we certainly have a ways to go. We also know that once genetic testing is done and there's a known mutation in a family, family members don't get tested. So we recently launched what we call a cascade testing initiative. And this just means when we talk about cascade testing, we just mean letting other family members know and enabling their testing. This seems like it should be very easy, but if any of you have family members that you find it hard to talk to, not that that ever happens, we really need to come up with sort of different approaches. So we're using everything from chat bots and text messages and family letters and things like that. And there's a lot of ongoing discussion and work on the issues of population screening, meaning widespread offering of genetic testing. So just to kind of give you a few specific examples, again, my colleague Angela Bradbury has a telegenetic service model with remote video conferencing or phone services. She's built up a large telegenetics program, and this has allowed us to do many different things. Currently, there is a direct patient access program available, and how we can sort of scale this up. We're working on, she has different contract models as well. So we're really interested in sort of, again, this as one of the approaches to take, which embeds genetic testing within a medical model with physicians and providers in an electronic medical record, but tries to decrease some of the barriers. In addition, Dr. Bradbury has a study called REACH, which will randomize 400 patients to either in-person counseling or web-based counseling, and vice versa at the time of results disclosure to get a sense at how this increases uptake, satisfaction, and knowledge. So these, are important aspects because we really have to figure out how to streamline genetic testing in a way that is gives us the information that we need for patients. Similarly, a project which I have been the lead on at Penn, which is a study done in New York, Boston, LA, and Philadelphia called the BRCA Founders Outreach Study. This study was screening for BRCA1 and 2 mutations in the Ashkenazi Jewish population, in this case, the 3 common Ashkenazi Jewish founder mutations. We have now enrolled more than 4,000 patients in this study. We're closing to enrollment in March of this year. We've learned a tremendous amount about how to do this. And particularly in this study, we were very interested in trying to engage primary care physicians, and that didn't always work. And so we have a lot of work to do in that area, sort of figuring out how to engage individuals in the general population about testing, but also how to work with primary care doctors to get this done. So you'll hear a lot more about that as our results come out. In addition, we have instituted a system to test every metastatic prostate and every pancreatic cancer patient at Penn. This was a joint protocol with Memorial Sloan Kettering, and in this case, this is done via a video, pre-test education video for genetic testing, and with a results disclosure by a genetic counselor. In this case, this is very important because patients with pancreatic and metastatic prostate cancer need this information to make decisions about how they're going to be treated. We're going to talk about that more later. And just to give you an example, even though we had offered genetic testing to individuals who had family histories or were of Ashkenazi Jewish with these conditions. We tested very few of them, but the minute we started doing this in the clinic, we've now tested more than 800 individuals with these conditions and identified a number of individuals with mutations in various cancer susceptibility genes. So we're trying to roll this out, make it available in a large scale. To change gears a little bit, we're really interested, and there were a number of questions about things such as prevention. And just to kind of get us started with how we think about that, one really novel and important area, and at Penn, we really do have a depth of experience related to immunology. And so we're using that depth to collaborate to really better understand the baseline immune responses in BRCA1 and 2 mutation carriers. And in order to do that, we're doing a rather, on the surface, simple experiment, but it actually it has a great deal of science behind it, looking at specific immune responses to the seasonal flu vaccine and looking at that in BRCA1 and 2 mutation carriers and in individuals with cancer and in individuals without cancer to look at the variation in those responses. And so that study has just gotten off the ground as part of a very large international study to better understand the issues related to immunology and cancer in BRCA1 and 2 mutation carriers. So that gets us at prevention. And, we're at the University of Pennsylvania, where Ben Franklin has famously said an ounce of prevention is worth a pound of cure, and we certainly believe in that. We also believe that surgical prevention techniques are not where we should be ending, and that we need to come up with better strategies than removal of the breast, early removal of the ovaries. So we're very keen to figure out other ways to do this. So one very exciting area is the potential use of a vaccine. And we had previously completed a study of 93 patients using a vaccine against something called telomerase, given with something called IL-12, which is kind of an immune stimulant. And eventually we treated 93 patients who had various cancers, breast, lung, pancreas, or ovarian cancer, who were at risk for relapse. So they had no evidence that their cancer was active. They appeared to be, if you will, in remission, and they were given this vaccine. And what we saw from this study was that it appears safe, and it did generate an immune response. So I'm really excited to say that we have prepared and actually submitted to the FDA a protocol to vaccinate first, a small number, but 28 healthy BRCA1 and 2 mutation carriers with this specific vaccine. For those of you who don't know, the submitting to the FDA to give an experimental drug to healthy people does require them to sign off on it. So this was submitted about a week and a half ago. They have 30 days to give us comments, but we're hopeful that this will move through because we've given it a lot of careful thought. And so we hope that we'll be able to get this study started this year. And again, the initial study will be small, just to prove that it's safe in healthy people, that it generates an immune response, and then we'll go from there. There's a lot of other stuff coming in prevention as well, and I can take more questions about this when we get to that section. But in addition to vaccination strategies, there's a great deal of interest in using medications that, of all things, we use for bone health. We use to treat osteoporosis, a drug called denosumab, which you may know of as Prolia. And in animal models, it seems to prevent BRCA1-related breast cancers for complex reasons. So a clinical trial has begun in Europe and is soon to, fingers crossed, open in the United States for this. This has been a little bit complicated. The clinical trials are complicated, but hopefully this will also be off the ground this year as well. There are different hormonal approaches, including some sort of newer drugs that could potentially prevent breast cancer, and those studies should be going soon. A study led by Judy Garber at Dana-Farber. We're going to talk about PARP inhibitors for treatment, and I'll talk to you a little bit about what we need to do to kind of start thinking about whether we can use these drugs for prevention. In addition, we really are interested in the concept of just removing the fallopian tubes. I'm going to talk more about this. and improving risk stratification. And what I mean by that is that we are getting better, at least in research studies, at understanding who's at higher risk, even within people who have BRCA2 mutations, who may be at higher risk for breast cancer and at lower risk for breast cancer. So those sort of that is kind of coming to the clinic probably pretty soon. How exactly we're going to use that information is a little complicated, but we've made a lot of progress in that. And in fact, this year's global award winners, Antonis Antou and Doug Easton, have really played a large role in trying to further risk stratify BRCA1 and 2 mutation carriers. When we talk about removal of the fallopian tubes, otherwise known as salpingectomy, why think about this at all? And I think that for those of you on the phone who have undergone preventative oophorectomy, you know that taking out your ovaries at a young age has negative consequences, and including hot flashes, night sweats, concerns about bone and cardiac health in the long term. There have been, and because of this, there are a reasonable number of people who delay or refuse sort of having their ovaries out at the time that we might otherwise suggest doing it. Now, there are studies that have been done by Ronnie Drapkin here in Penn and others that have shown that a good number, if not all, there's ongoing scientific debate, and we'd like to debate ourselves, but at least a really good portion of ovarian cancers appear to arise in the fallopian tube. So the idea is maybe you could just take out the fallopian tubes at an earlier age and then leave the ovaries in until later and take the ovaries out at a delayed time. So there's a study called WIF, Women Choosing Surgical Prevention. This is the overall PI in the country is Karen Liu at MD Anderson. At Penn, the leaders are Sarah Kim and Ronnie Drapkin. And this study is called WIF, but a parallel trial that's in Europe is a study called TUBA. And so these two trials are sort of going to combine to look at the analysis. Now, I will say that the tricky part is that the initial study was powered just to look at whether or not people who only had their fallopian tubes out had fewer hot flashes than people who had their ovaries out. And I can tell you that we actually know that answer already. More challenging is going to be sort of the risks of cancer. And I'll give a specific example. If someone has a BRCA2 mutation, our current sort of guidance is that the risk of ovarian cancer before age 45 is actually quite low. And so women can kind of wait until more like 40 to 45 if they have a BRCA2 mutation. So if someone's 35 and done having their children, well, and they need birth control, it can make a lot of sense to just get the fallopian tubes out at, say, 35, and then get their ovaries out, say, at 45, which is still in the range that we would consider acceptable. And so that, does that prove that taking your ovaries, taking out your fallopian tube works and that you could leave your ovaries in till 50? No, it doesn't prove that. So I think we're going to have to be really careful about looking at the data, and particularly for BRCA1, where the ovarian cancers come younger, we're just going to have to be very careful to look at the data honestly, because another approach is to remove the ovaries and then take back hormone replacement therapy, which we definitely offer to people who have not had a breast cancer. So these are, some of the active issues, and it's really exciting that these studies are getting done. Women volunteer to participate in these studies so that we can get answers to these important questions, but we also don't want to rush into it. We want to really know what the risks and benefits are. Another strategy is to try to improve our detection of ovarian cancer. I think this group knows that ovarian cancer detection is actually quite challenging, and the current methods like ultrasounds and blood tests with CA-125 don't work particularly well. So one approach is to try to do, almost a pap smear of the fallopian tube. So this particular technology, and run by Envision Medical, is to determine if this type of procedure, cytuity it's called, can collect cells from the fallopian tubes and then have those evaluated and sort of see if they look funny. And this is kind of how you do a pap smear. You take a sample, the cells look funny, then you go from there. And so again, Sarah Kim and Ronnie Drapkin have been very involved in this and have enrolled a large number of patients, and this study is ongoing to really determine how well this works and whether this could be a strategy instead of a removal of the ovaries. Now, when we get at treatment, just a short reminder, we often talk about PARP inhibitors. So I'm going to briefly explain sort of how PARP inhibitors work. So just as a reminder, individuals with a BRCA1 or 2 mutation, they are born with one bad copy of, say, BRCA1, and in most of the time in the tumor cell, here represented in green, the cell loses the second copy. So there is no BRCA1 protein, and this leads to what we call homologous recombination repair defect. And so this cell in green is like that. Meanwhile, this cell in blue is a normal cell that can repair DNA completely normally. Now, every day your cells get damaged, have DNA damage by all sorts of causes. And in the setting of having you can manage that fine if only one thing is wrong with the cell. But if you add a PARP inhibitors block a second type of DNA repair pathway. So in the setting of having just one kind of problem, if you have both problems and they're both knocked out, these repair pathways, the cell dies. Whereas if you only have one problem with the PARP inhibitor knocking out one repair pathway, the cell can survive. And so this is, again, the concept of synthetic lethality, that if you only have one problem with your cells, they can survive. But if you accumulate two problems with the cell, then the cell will die. That's the fundamental concept behind how PARP inhibitors selectively work in BRCA1 and 2 related cancers. So PARP inhibitors have had a really interesting time since 2014. There have been multiple approvals of PARP inhibitors for ovarian cancer. Olaparib, rucaparib, niraparib have been approved in ovarian cancer. And there's also been approvals in breast cancer with olaparib and talazoparib. Veliparib may or may not be close behind, but this is in combination with chemotherapy. This is data that I presented last year, but what was exciting for this year is that in addition to breast and ovarian cancer, one of the PARP inhibitors called olaparib has now been approved for BRCA1 and 2 mutation-associated metastatic pancreatic cancer, and this happened on December 30th, 2019. And this was very exciting, and this was based on a study randomizing patients to continue chemotherapy, who had had chemotherapy to either a sugar pill or olaparib. So this at least gives individuals an option. We've done multiple studies in this space. My colleague, Kim Rees-Binder, we did not participate in the POLO trial where patients were randomized to placebo. We instead did a straight-up phase 2 trial where individuals with metastatic pancreatic cancer received chemotherapy, and then if the disease was at least stable on chemotherapy, they moved on to one of the PARP inhibitors, in this case, rucaparib. We've had some really nice results. We've completely recruited, 42 patients, and at this time, 50% of patients remain on study. We don't have all the final results yet, but we'll suffice it to say we've had really long-standing responses. And again, these are pills that people every day, and this is metastatic pancreatic cancer. We are doing follow-up studies. In this case, again, this is Kim Rees-Binder, looking at PARP inhibitors with different combinations of immune therapy drugs to see how that can be helpful. And doing a whole series of corollary science, including specialized imaging, which has also been developed here at Penn, something called PARP PET imaging, and additional collections for DNA sequencing and others. In addition, Kim is now leading a international study looking at, again, rucaparib, one of the PARP inhibitors, for individuals with pretty much any kind of cancer that have a BRCA1 or 2 mutation. Now, this is not available for people who, for instance, have metastatic breast cancer who have a BRCA1 or 2 mutation, because there's other studies for them, and the drugs are already FDA approved. But for instance, if an individual has a colon cancer or uterine cancer and has a BRCA1 or 2 mutation, this is a study. And so as of today, there's now 3 patients enrolled. This just opened in December. This is going to be a really nice option for patients. Another really important question about PARP inhibitors is whether if you give PARP inhibitors earlier, you can get a better outcome. So to show you 2 examples of those trials, again, Kim working through something called the ECOG Cooperative Group. This is one of these very large cooperative groups in the United States. Is going to be looking at individuals who have resected pancreatic cancer. A lot of pancreatic cancer patients present when the cancer is already spread, but in this case, it'll be individuals who have resected pancreatic cancer who have mutations in either BRCA1 or 2 or another gene called PALB2, and they'll get all their regular treatment exactly how they should have, and then after that, they'll be randomly assigned to either get a rucaparib, one of the PARP inhibitors, or a sugar pill. So this trial should be opening later this year and will be a really important trial. Meanwhile, in the breast world, we have completed a large study called Olympia, which randomized 1,800 BRCA1 and 2 mutation carriers with breast cancer. Again, all their therapy was completed, and then they would get olaparib versus a sugar pill. This study closed last year. We're waiting for the results. There's going to be a lot of, again, interesting corollary science. And it's going to be really, really important to see what the side effect profile was in the group that got olaparib for a year, even though they didn't have advanced cancer. This is going to be our best way to get good safety data to then start thinking about using these medications in the prevention setting. So again, this is important, and hopefully we'll be hearing more about that soon. There were a couple of questions about BRCA-associated prostate cancer. The risk is higher for BRCA2 mutations than for BRCA1. We've had long-standing involvement in something called the IMPACT study, looking at prostate cancer screening led by Roz Eels in the UK. One of my colleagues, Kara Maxwell, is looking very deeply at the tumor and germline of BRCA1 and 2 prostate cancer patients in something called the Penn Medicine Biobank. As mentioned, we've been increasing our genetic testing via the point-of-care study, and we've been trying to increase our access to clinical trials. We just completed a clinical trial called Javelin, which is a multi-center trial where we enrolled patients to receive a PARP inhibitor plus an immune therapy agent with all kinds of cancers as long as they had BRCA1 or 2 mutations. There's a new study that we're about to launch. And we do anticipate that there will be approval for olaparib in BRCA1 and 2 mutation-associated prostate cancer this year, and likely rucaparib will also be approved. And so we'll have 2 drugs in that setting as well. So it's just really exciting things. Just to mention a couple of other studies, we're very interested in how to combine drugs to get better responses. This work, led by Fiona Simpkins here at Penn, combines a PARP inhibitor plus a drug called an ATR inhibitor, with the hopes that this can prevent or reverse resistance to different medications. This is called the CAPRI study, and it's in ovarian cancer. My colleagues Dan Powell and Payal Shah have been looking at generating T cells, these CART T cells, which are engineered T cells, to attack ovarian cancer. Ovarian cancer is expressing this folate receptor. So this is in an early stage, but I think now 4 patients have been treated, and the safety looks good. And so this is continuing. Again, this is an immune therapy, specialized T cell therapy study. And another study by my colleague, Dr. Shah, looks at combining, this is for BRCA2-related breast cancer, combining olaparib endocrine therapy with a drug called fulvestrant and another drug called palbociclib to see if you can, again, improve responses in that setting. So a lot of different clinical trials going on. We have a lot of basic science, and I'm not going to get into the details of this today because I want to get to the questions, but we really are interested in looking deeply at how BRCA1 and 2 interact with themselves, with other cellular processes, and with the immune system. And we still don't understand why BRCA1 and 2 mutations lead preferentially to breast, ovarian, and to a lesser extent, prostate and pancreatic cancer. The more we understand this, the more we can understand prevention, and also we can understand why tumors may or may not be responsive to therapy. So the basic science, sometimes which is harder for us to explain, we're never really sure what direction these really basic questions will go in, but they're critical to our success. That's how we ended up with PARP inhibitors. No one really thought that would work, but then somebody tried it, and it did, and that's pretty cool in the end. We work with a lot of different people here at Penn, physicians, genetic counselors, nurses, research coordinators, people in the lab to do this and advance the field. So I'm the messenger trying to consolidate all this work, but there are just a ton of people behind the scenes. So I'm going to start the questions because, again, there are a bunch, and this is usually the thing that people most want to hear. Someone has asked the question that I alluded to, which is in the clinical trials investigating salpingectomy with delayed oophorectomy, have there been any interval cancers up to this point? And I don't know the details. It has not been reported that as such. But again, the devil's going to be in the details of how long people really waited to get their oophorectomy. As stated, the risk of developing ovarian cancer before age 40 in a BRCA1 carrier is 2%, and it's only about 2% by age 45 for BRCA2. So you actually have to have a lot of people come on these studies to really answer the cancer question, and that's going to be really important. So this is a great question, so important. What does research show about the risk of cancer for individuals that test negative for known BRCA mutations in a family where many carry the mutation? Such an important question, and in fact, in the early days, one of the initial reasons that people felt so strongly about letting families know about this information was not only that you could say, oh, you should act on it, but in those early days, we were testing families that had dramatic family histories of breast and ovarian cancer. I mean, these were families that, so many relatives had breast and ovarian cancer. So a critical question was, if you're negative, are you off the hook? And so several studies have been done. We have done studies, and there's been a large study by a cooperative group called Embrace based in Europe. And in that study, they followed more than 1,800 BRCA1 and 2 mutation 1,800 individuals who tested negative for the known BRCA1 or 2 mutation in their family. And the great news is that those women weren't at any higher risk of developing breast or ovarian cancer than the general population. Having said that, the general population gets breast cancer, and in the United States, we still do, mammograms generally at age 40. If there is a branch of the family, for instance, if there's cancer on both sides of the family, lots of breast cancer on both sides of the family, that may change. We may still do enhanced imaging. So it does matter exactly what your family history looks like, but in general, we revert to the general population guidelines unless there's something about the person or about the family. Another question is regarding men, and this is so critical. As I think people on the call know, if you lined up every mutation carrier in the world, half of them would be men. If an individual has a BRCA1 or 2 mutation, they pass that along to their children, 50-50 chance each time, including their sons, not just their daughters. And men do have increased risk of cancer. Those cancers are less than for women. They are higher for BRCA2 than for BRCA1. Again, why men sort of get hit a little harder for BRCA2, we don't really know. The risk to men for breast cancer, the lifetime risk is sort of in the 7% range, which might not sound very high, except when you say that an average American man has a risk of male breast cancer of 0.1%. And then suddenly that really puts it in perspective. For breast cancer risk, we definitely urge men to be aware that they can get breast cancer and to have breast exams starting at sort of 40 to 45. I tend to be, and this is where there's not really great consensus. There's kind of this consideration of doing mammograms. I do tend to get them if men have breast tissue, and a lot of men do have breast tissue. And so we kind of individualize that, but consideration of mammograms is important, particularly for BRCA2, but for BRCA1 as well. We do prostate cancer screening, again, starting at sort of that 40 to 45 range. We do PSA screening, which you may hear doesn't work very well in the general population. That may be true, but it does appear to work pretty darn well for BRCA1 and 2 carriers. We also, talk about things like for BRCA2, there's a slight increased risk of melanoma, so keeping an eye on the skin, potentially getting dermatology exams. And the key question is what to do about pancreatic cancer risk, and I think there's another question in here as well about pancreatic cancer risk. This is an incredibly hot area of research. It's an area that we know that we need to do a lot more work on. Currently, there are a number of different studies, including something called CAPS-5, which is a multi-center trial run out of Hopkins. And CAPS-5 offers a pancreatic cancer screening to individuals who have either 2 relatives with pancreatic cancer or who have a BRCA1 or 2 mutation, for example, or an ATM or PALB2 mutation, and a first-degree relative with pancreatic cancer. And so those studies generally involve endoscopic ultrasound or abdominal MRI. Abdominal MRI particularly isn't often covered by insurance, at least it's not at Penn in our catchment area. But we do talk to patients about pancreatic cancer screening. We also have an open study for endoscopic ultrasound for BRCA1 and 2 mutation carriers who don't have a family history of pancreatic cancer. In that, we're really starting screening at around 60, but we have to be clear that we don't know how well it works. Pancreatic cancer is a very difficult cancer, and you definitely want to catch it early, but it's not clear that a yearly test like that is going to do the trick. So there's a lot of work on blood-based tests to try to detect pancreatic cancer earlier. So that's something that is an area of active interest at a lot of places, and I think you're going to hear a lot more about pancreatic cancer screening. All right, so let's see. All right, there's a few different questions about birth control, so let me try to kind of summarize how we think about this. Birth control, we'll start with birth control pills, so oral birth control pills. Really have been shown to decrease the risk of ovarian cancer by about 50%. The risk of developing breast cancer in the general population has shown to be that there is a slight increased risk of breast cancer. And it is likely true that there may be a very slight increased risk of breast cancer in BRCA carriers as well. So this all has to be kind of weighed. There are good things about birth control pills: controlling painful cycles, mood, acne, not getting pregnant, decreasing risk of ovarian cancer. On the other side, blood clots, the birth control pills are also associated with an increased risk of blood clots and this potential slight increased risk of breast cancer. So it's a really individualized decision about that. Something like a copper IUD, a non-hormonal IUD, does not have any hormonal therapy associated with it. Some women have irregular bleeding associated with copper IUDs, and it doesn't provide you with the other benefits that we discussed. So, it's really an individualized decision, and in general, it's not viewed as a contraindication. Having a BRCA1 or 2 mutation is not considered a contraindication because you really have to look at the larger picture. All right. Let me just looking at my. Okay. Oh, this is a good one. There was a question about PARP inhibitors for ovarian cancer, and I admit that I probably went over this too quickly. So let's talk about ovarian cancer. These were the PARP inhibitors were first approved in ovarian cancer. The first approval was treatment of ovarian cancer where women's ovarian cancer had come back multiple times, and the individuals had received at least 3 prior lines of chemotherapy. So that was sort of at a later stage, and that's often true how drugs get approved. They get approved in a later stage, and they get moved up earlier and earlier and earlier. So that has happened in ovarian cancer, and again, extremely exciting. And for BRCA1 and 2 mutation carriers, it's become critically important that individuals with newly diagnosed ovarian cancer get genetic testing, because if they go through their initial chemotherapy, there's now very good data there are now very good data that those individuals that taking a PARP inhibitor after their chemotherapy can significantly reduce their risk of their cancer coming back. So it's really critically important that we know whether someone has a BRCA1 or 2 mutation. There's other issues about PARP inhibitors in ovarian cancer, and these drugs actually work beyond people who have germline mutations in BRCA1 and 2, but individuals with BRCA1 and 2 mutations appear to have the most significant benefit. So that's why it's quite important. One of the studies that I alluded to, the CAPRI trial, is actually trying to figure out how to make those drugs work better, longer, and if a tumor becomes resistant to the PARP inhibitors, how to overcome that resistance. Okay. There was a specific question about talazoparib. Talazoparib is approved by the FDA for treatment of metastatic breast cancer. Again, there are 2 drugs approved for breast cancer, olaparib and talazoparib. The drugs approved for ovarian cancer are olaparib, rucaparib, niraparib. The ARIB, by the way, A-R-I-B, is the sort of the PARP inhibitors. So talazoparib is, they're all, we're lucky we have choices. There can be slight differences in side effect profile. This drug is also being studied in patients with initial diagnosis of breast cancer to get their treatment first and then go to surgery. So I think that it's also a very active PARP inhibitor. A question about whether or not the uterus needs to be removed at the same time as the ovaries. So this is based on studies that have been done looking at whether or not individuals with BRCA1 and 2 mutations have an increased risk for uterine cancer. In general, the data do not suggest an overall increased risk of uterine cancer overall. However, there is a specific subtype of uterine cancer called a uterine papillary serous carcinoma that does appear to be at a slightly higher risk, particularly for BRCA1 mutation carriers. Having said that, in a large trial where there were over 1,000 women that had their ovaries out and left their uterus in place, there were 5 cases. So it does have to be kept in perspective. And the lifetime risk of developing a uterine cancer is estimated to be in like the 2.7% range, and that's over one's lifetime. Having your uterus out can be a more complicated procedure depending on a woman's personal risk factors, such as whether she's had multiple C-sections or something like that. In addition, some people really don't have a lot of time to take off work, and it's not, and the potential for a longer recovery time and potential increased complications has to play a role. Another thing that plays a role in our decision making, though, is have people had abnormal pap smears? Do they have abnormal uterine bleeding? Do they have fibroids that are a problem for them? And are they going to take hormone replacement therapy? Hormone replacement therapy decisions are impacted by whether or not you have a uterus because of how we give HRT. If a woman does not have a uterus, we can give estrogen by itself. Estrogen by itself, strangely, in studies that have been done, does not increase breast cancer risk. It's estrogen with progesterone that seems to increase that risk of breast cancer. And if you have a uterus in place, you can't give estrogen by itself because giving what we call unopposed estrogen increases the risk of uterine cancer. So as you can see, this is a nuanced and complicated discussion that we have with women. What are their own personal risk factors, and what is their plan for hormone replacement therapy, and then we help them make the decision about the uterus or not. But it is absolutely not one of those situations where absolutely everyone should have their uterus removed. Fallopians and ovaries absolutely should be removed. There should be a discussion about the uterus. Okay, so data on PARP inhibitors for BRCA2 hormone receptor positive breast cancers. Well, I have good news on this. Every study that has been done, the initial trial, which we ran called, Study 42, because we don't come up with creative names, the study before that called Iceberg, and then both Olympiad and BRCA, which were the studies that got olaparib and talazoparib approved. In all those studies, 50% of the individuals on the metastatic breast cancer trials for PARP inhibitors had estrogen receptor positive disease. And in all the cases, the response rates were the same, whether the tumors were triple negative or estrogen receptor positive. The study that I mentioned is trying to sort of see whether or not if you can combine hormonal and other types of treatments with the PARP inhibitor, whether we can get even better data. But there's no reason there are no data that hormone receptor positive breast cancers respond any less well, which is great. Okay. I'm not sure exactly what that question reads. So how do we join studies? Yes, we would all love you to join studies. Through the BASR website, there is actually a way to join studies for that. The studies that are easiest to do remotely are studies where we are actually looking for modifier genes. So oftentimes we just have you spit in a tube and give us your information, which we update on a regular basis. When people are in Philadelphia or near our area, there's a lot of other potential study options available, including we draw blood once a year to again look for different ways that we can potentially detect tumors in the blood. The immune studies that I mentioned as well. So feel free to contact us through our website, and we'd be happy to talk to you about any particular trial that you're interested in. There was a question about in 10 years, will there be new ways to prevent breast cancer? Let me tell you, in 10 years, if there aren't, I will be very disappointed in myself and everybody else. This really, I can't emphasize enough how much we want to have other things to offer to patients. So we are working on it, and I really do think that we will have other things to offer. Okay, I think I answered the question about pancreatic cancer screening. Again, if you have a family history, usually we talk about age 50 or 10 years prior to the earliest diagnosis. And if there's no family history, we at Penn are doing 60, but there's no consensus on that. And I want to be clear, there's no guidelines saying that individuals with no family history of pancreatic cancer should get screening. So you should look for ongoing potential studies. A question about, I'm BRCA1 positive, so is my daughter and mother. My mom had breast cancer at 49 and diagnosed at 36. What age should my daughter start being monitored? We start at 25 at this. We actually do start breast MRIs at 25. We do yearly breast MRI till 30. At 30, we add a mammogram to the MRI and then sort of go from there. I'm now doing rapid fire, by the way. Hormone replacement therapy. At Hormone, I have alluded to this, but we will never have a randomized control trial of women having had their ovaries removed and then randomly being assigned to hormone replacement therapy versus no hormone replacement therapy, because it doesn't work that way. Women, are choosing to take it because they're having symptoms and whatnot. If a woman has had a bilateral mastectomy, her risk of developing breast cancer is now in the 1% to 2% range, and it's all good. Even if a woman has not had a bilateral mastectomy, though, we do discuss hormone replacement therapy. The way that I look at this is that if you think about the total amount of estrogen you have over your lifetime, when we give estrogen replacement back, we don't give sort of the exact, we don't give sort of the level at which you already were. And we took your ovaries out, not to take your estrogen away. We took your ovaries out so that you didn't develop ovarian cancer. So we do offer hormone replacement therapy, and as mentioned, in this very large study called the Women's Health Initiative study, in that study, it was not BRCA1 and 2 mutation carriers, but it was thousands and thousands of women who were randomly assigned to hormone replacement therapy versus sugar pills. Now, on average, they were 63 years old, so a very different population. But in that study, women who received estrogen alone did not have an increased risk of breast cancer. So that's another place where when I'm talking to someone about hormone replacement therapy and I'm talking to them about their options, that is something I discuss with them. Okay, this is a good but complicated question about hormone replacement therapy for triple-negative breast cancer. One of the challenges here is that there is a black box warning label on all estrogen that says that if you've had breast cancer, you should not take the product. We have absolutely no issues with vaginal estrogens in triple-negative breast cancer patients, and I usually do try to use other things besides hormone replacement therapy at first. There's other strategies, acupuncture, drugs called SSRIs, and things like that. And there has been a study called the HABITS trial, which randomized people after a breast cancer diagnosis to hormone replacement therapy versus none. That study showed that women who had estrogen receptor-positive breast cancer had an increased risk of recurrence with hormone replacement therapy, which is probably not a surprise. It didn't show much in triple-negative, but that study was not large enough to really show an effect. So again, you're getting the sense, depending on how miserable people are, it's not off the table for me, but it has to be done with full consultations. Okay, does the risk go down as one gets older? Great question. It's not so much that it goes down, it's just, think about it this way, you've got a cumulative lifetime risk. You have a risk from age 25 to age 80. And if you make it to 65, and you say, let's say that from 25 to 80, your risk is 70%. We know that if you're 65 and haven't had breast cancer, your risk is no longer 70%. And in fact, different kind of studies have been done showing that it's absolutely no more than 20%, and it's probably much lower than that. So it's about a cumulative lifetime risk. So I'm hoping that helps. There was another question about pancreatic cancer screening with 2 cases of pancreatic cancer in their 60s, and definitely in that case, we do start at age 50 for sure. If their ages of diagnosis were earlier, we may have that be different. I think prostate cancer and PARP inhibitors, when it will be approved, I really do think it'll be approved this year. Typical recovery time for someone with a bilateral mastectomy completely depends on your reconstruction. Having a flap reconstruction with taking the tissue from your belly, the recovery time is definitely longer than, say, a single-step reconstruction with implants or no reconstruction. So usually I really have people meet with plastic surgeons first to understand what their reconstruction options are and to get a better sense of what their recovery time is. There was a question about essentially what we call the birth cohort effect, which is whether or not the ages of onset get earlier in successive generations. You know, that has been seen, but I got to tell you, it is a little complicated because once you start screening for cancers, you're going to diagnose them earlier. So I mean, we have to be careful, and we're paying attention to it. But as is, we do start a lot of our screening earlier, much earlier than the average age of cancer. So for BRCA1, the average age of breast cancer is 43, and we start at 25. So you're kind of noticing that we're already giving ourselves a wiggle room. Okay, there are so many questions. I think I have time for one more, and just questions about BRCA1 and other cancers besides breast, ovarian, prostate, pancreatic. You know, there is, what we know is that when people do sequencing, they can find genes in cancers other than the classic cancers. but what we don't know is whether they're associated. So saying that another way, someone can have a BRCA1 mutation and get lung cancer, but that might be because they smoked or et cetera. So we don't know about the causality. This is something that people are paying a lot of attention to right now. And right now we know that there's kind of a slight global increased risk of cancer overall, but not enough to call out anything particular. So what I'm going to do, because we try to do this every time, is that Sam will put together the list of cancer of questions that I did not answer, and we will post them on Facebook or the website or something like that. Right, Sam? Tell me what we're doing just to try to get at the rest of the questions.
Yep, usually whenever we have extra questions, we'll do short little videos answering them over the next couple weeks. So you could definitely look for those on our social media accounts. We're on Facebook, Twitter, and Instagram, and our handle is @BassarBRCA. And we also usually post everything on the website as well or on our YouTube page.
All right. Well, thanks to everybody again. Sorry I ran a little over and didn't get to all your questions, but we will try to address them shortly. All right. Thanks so much.